I'd like to take a few moments to address some of the discomforts and conditions that may accompany pregnancy. While the fetus is growing, its needs for oxygen and nutrients place extra demands on the mother's lungs, heart, metabolic, and digestive systems. Heartburn is a common complaint, especially as pregnancy progresses and the fetus is taking more and more space. This can increase the pressure on the stomach and cause its contents to be pushed back up the esophagus. In addition to the physical changes, the hormone progesterone produced by the placenta relaxes the muscles in both the uterus and the gastrointestinal tract. This allows the woman's body to change to accommodate for pregnancy and delivery, but it can also lead to a more relaxed sphincter between the stomach and the esophagus, allowing stomach acid to move back up the esophagus and causing heartburn. Some steps a woman can take to manage heartburn is to use gravity to her advantage and stay upright after eating. It may also be helpful to eat less fatty meals, as fat takes longer to move out of the stomach and into the small intestine. For some, spicy foods can aggravate heartburn and should be avoided. It is also recommended to consume more frequent smaller meals and drink liquids between meals rather than with meals to prevent the stomach from becoming too full and lead to more heartburn. If these lifestyle changes don't improve heartburn symptoms or the symptoms are severe, a doctor may recommend the use of an antacid or other heartburn medication. Constipation can also result from a hormone-mediated relaxation of smooth muscles. This process is beneficial to accommodate for the fetus, but may slow down the passage of food in the GI tract. Regular exercise, added fluids and fiber, as well as dried fruits such as prunes, may alleviate constipation. The adequate intake for fiber is 28 grams during pregnancy, and fluid needs increase to 10 cups per day. Hemorrhoids result from straining during bowel movements. This condition can be lessened by decreasing constipation and potentially adjusting the dose of iron supplementation, which can also lead to constipation. Up to 85% of women experience nausea in early pregnancy, and while morning sickness is a term frequently used to describe this, the nausea can occur any time of day or night and persist all day. A stronger sense of smell related to pregnancy hormones may be related to mild nausea. For relief of nausea, avoiding foods that aggravate it is of course recommended. Good ventilation during cooking can help lessen the problem. It might be helpful to eat a small amount of carbohydrates, such as dry crackers or cereal, right before getting out of bed in the morning, and avoiding large amounts of fluids early in the morning. Smaller, more frequent meals are also recommended. The type of iron supplement may also need to be changed if it makes symptoms worse. In addition, the American College of Obstetricians and Gynecologists recommend the use of a multivitamin at the time of conception. 10 to 25 milligrams of vitamin B6 taken 3 to 4 times per day, along with the antihistamine doxylamine. A dose of 350 milligrams of ginger supplements can also alleviate the symptoms. Thankfully, for 80 to 90% of women, nausea and vomiting come to an end after the first trimester. If vomiting continues or is severe, medical care should be sought. Edema, a result of placental hormones signaling the body to retain fluid, and blood volume increases, is a normal part of pregnancy. Water intake should not be restricted, and while sodium intake should stay within normal recommendations, it doesn't need to be restricted below that. Elevating the feet or wearing compression stockings may provide some relief. If edema is accompanied by hypertension or extra protein in the urine, preeclampsia, which we'll talk about later, may be present. Blood volume in pregnant women expands to 150% of normal. while red blood cells only increases by less than 30%. This imbalance in ratio of red blood cells to blood volume is called physiological anemia. While this is normal during pregnancy, this phenomenon, compounded by inadequate iron intake and increased iron demands, can result in iron deficiency anemia and require iron supplementation. Another condition impacted by placental hormones is gestational diabetes. The hormones decrease the efficiency of insulin, resulting in a slight increase in blood glucose. If the rise of blood glucose becomes excessive, it leads to gestational diabetes. While gestational diabetes can happen to any pregnant woman, risk factors are a family history of diabetes, obesity, maternal age over 35, and previous gestational diabetes. Gestational diabetes occurs in 4% of pregnancies, and for women without type 2 diabetes, a screening should take place around 24 to 28 weeks of pregnancy. This screening involves ingesting 75 grams of glucose in a solution and checking for blood glucose concentrations after 1 to 2 hours. If gestational diabetes is diagnosed, a diet that evenly distributes carbohydrate intake throughout the day is recommended. Carbohydrates should come from whole grains, vegetables, fruit, and beans. Insulin injections or medications may be needed to further control blood glucose. Participating in regular physical activity is recommended. Complications of uncontrolled diabetes include a larger fetus, which may result in a greater risk of C-section if the baby becomes too large for vaginal birth. In uncontrolled diabetes, the fetus also has a tendency to produce more insulin, which can result in low blood glucose at birth. Infants are then at greater risk for obesity and metabolic syndrome later in life. Gestational diabetes often goes away after birth. However, the mother is at greater risk for developing type 2 diabetes later in life. A blood pressure higher than 140/90 is considered hypertension. This occurs in 6 to 8% of pregnancies. In about half of the cases of gestational hypertension, preeclampsia or eclampsia develop. Preeclampsia is milder than eclampsia. Signs include increasing blood pressure, excess protein in the urine, edema, headaches, and visual disturbances. If not controlled, eclampsia can lead to liver and kidney damage, as well as death in both mother and fetus. While the cause is not known, overweight and obese women, women under 17 or over 35, those who have had multiple birth pregnancies, a history of gestational hypertension in the family, diabetes, African American race, and those who are pregnant for the first time are all at increased risk. The only treatment for the mother is delivery of the baby, but bed rest and magnesium sulfate are used to treat the condition until the baby can be delivered. Adequate vitamin D and calcium intakes result in a reduced incidence of gestational hypertension.